Welcome back to the deep dive. Today, we're taking on a fortress, a highly complex, incredibly functional anatomical region we use every single day,
Yeah,
the human mouth.
we are. And we're using just one source for this, a chapter 37 of Gray's Anatomy, to build, a really clear mental map.
Right. So our mission is to build that three-dimensional picture from the lips all the way back and really understand how it all fits together.
Exactly. The mouth is for ingestion, sure, but also phonation, ventilation. It all starts here.
Huh.
And it's divided into two main zones.
Okay. Lay them out for us.
You've got the vestibule, which is sort of the entryway, the space between your lips and cheeks and your teeth.
The porch, basically.
The porch, exactly. And then you have the oral cavity proper, which is everything inside the line of the teeth.
Got it. So let's start on that porch with the gates and walls, the cheeks and lips.
Right. And inside, the cheek mucosa is tightly stuck to the buccinator muscle. And you can actually see landmarks in there.
Like the parotid papilla?
That's the one. It's a little mound opposite the upper second molar. It's the opening for the parotid glands duct.
And people often have that white line, the linea alba, right?
Mm-hmm. That's just a bit of hyperkeratinization where your teeth meet the cheek, a friction line. But if you go just a bit behind that, you hit a landmark that is absolutely critical.
For pain management, I'm guessing.
For nerve blocks. The entry point for an inferior alveolar nerve block, the one that numbs your whole lower jaw,
Yeah.
is just lateral to a fold called the pterygomandibular raphe. Knowing that spot is everything.
It turns a complex name into a really practical target.
Okay, what about the lips? They're not just passive structure.
Not at all. The strength of the orbicularis oris muscle actually controls how your incisors are angled, and they're filled with minor salivary glands.
Which is why if you bite your lip.
You can get mucosa, a little saliva retention cyst. It's just trapped saliva.
Okay, so back in that vestibule, you had the trough where the mucosa reflects, the fornix vestibuli, and the little tethers in the middle, the frenula. And that upper labial frenulum is a great clinical example. If it attaches too low on the gum,
It pulls the teeth apart.
it can, yeah.
Yeah.
It creates that midline gap, a diastema. And fixing it, a frenulectomy, is pretty straightforward because it's mostly just connective tissue.
So we've covered the entryway. What about when we step inside into the oral cavity proper? Let's start with the lining itself, the oral mucosa.
Okay, so it is definitely not the same everywhere. It's highly specialized. You have two main types,
Which are?
lining mucosa and masticatory mucosa.
And the difference is function, I take it.
Function and feel. Lining mucosa is on the soft, stretchy parts cheeks, floor of the mouth. It's non-keratinized, dark red, and loosely attached.
And the masticatory type.
That's for the high-impact zones, the gums, the hard palate. It's pale pink, keratinized for toughness, and it is firmly bound down to the bone underneath.
And there's a visible line between them.
Oh yeah, a very clear border. That's the mucogenal junction.
So let's look at the roost then, the hard palate. It's all masticatory mucosa.
It is, but it's special. The mucosa is fused right to the bone's covering, the periosteum. It forms a single unit called a mucoperiosteum.
Which means there's no give.
No give at all.
Yeah.
That's why injections or swelling there are so painful, the fluid has nowhere to expand.
And we can feel that midline seam, the palatine raphe, and then those ridges up front, the rugae.
Exactly. And those rugae are unique to each person, like a fingerprint. They help grip food.
Okay, let's drop down to the floor. It seems simple, but it's structurally fascinating.
It's a muscular diaphragm. It's basically two mylohyoid muscles forming a sling from the inside of the mandible down to the hyoid bone in your neck.
There's the divider between the mouth and the neck.
It is. And sitting right on top of it, under the tongue, you have the sublingual glands and the ducts of the submandibular glands.
Right next to the lingual frenulum.
Yes. And that frenulum, it's not a simple string. Graves describes it as a basket weave of fibers.
Which, if it's too tight, gives you ankyloglossia or tongue tie.
It does, but the text makes a good point that the evidence for surgery actually improving speech is, a bit scanty. It might be more about muscular control.
But there's a huge clinical point here about the floor of the mouth, isn't there?
Yeah.
The mylohyoid hiatus.
This is a beautiful piece of anatomy. There's sometimes a natural gap in the muscle, and if a sublingual gland cyst, a ranula, forms,
It can squeeze through.
it can herniate right through that gap. It's called a plunging ranula. So instead of swelling inside the mouth, the patient presents with a swelling in their neck.
Wow. That's a classic anatomical trap.
It really is.
And before we get to the tongue, what about the exit? The oropharyngeal isthmus.
That's the gateway to the pharynx. It's bounded by the palatoglossal arches, and they squeeze shut during swallowing to stop food from coming back up.
Okay. Now for the main event, the tongue. It's divided by that V-shaped line, right?
The sulcus terminalis, that's the boundary. The front two-thirds are oral, the back third is pharyngeal. And at the point of the V is the foramen caecum, a little pit.
A remnant of the embryonic thyroid gland. So let's talk about the surface of the tongue, the papillae. There are 4 types.
Right. First and most numerous are the filiform. They're tiny, hair-like, and their job is just friction, to grip food.
And the key fact.
They have absolutely no taste buds.
So they're just for texture.
Purely mechanical. Yeah. Then you have the fungiform, the little red dots. They usually do have taste buds.
And on the sides.
Those are the foliate papillae, like little leaf-like folds, also have taste buds.
And then the big ones at the back, in that V formation.
The circumvallate papillae. There are only about 8 to 12 of them. They sit in these little trenches, and the taste buds are on the walls of the trench.
So how do they stay clean?
That's the amazing part. Tiny serous glands, the glands of von Ebner, constantly pump fluid into the trench to wash away old food particles and keep the taste buds ready.
A built-in cleaning system. That's incredible. What about movement? The extrinsic muscles.
They move the whole tongue. The genioglossus is the big one. It protrudes the tongue.
The lifesaver muscle.
Because it pulls the tongue forward and opens the airway. Then hyoglossus pulls it down, and styloglossus pulls it up and back.
And the intrinsic muscles just change its shape.
Right. They work as a unit called a muscular hydrostat.
A hydrostat? What's that?
Think of an octopus tentacle. No bones. The muscles contract against the incompressible volume of the tongue itself. It allows for the incredibly fine control you need for speech.
That makes sense. Okay, innervation is famously complex here. Why is general sensation different from taste in the front part of the tongue?
It's all down to embryology. For the anterior two-thirds, general sensation, touch, pain is carried by the lingual nerve from the trigeminal nerve,
Right.
But taste signals travel on a completely different nerve, the chorda tympani, which is a branch of the facial nerve.
So, 2 separate pathways for the front. What about the back third?
Back there, it's simple. Both general sensation and taste are handled by one nerve, the glossopharyngeal.
And motor control. What makes the muscles move?
Almost all of them, intrinsic and extrinsic, are supplied by the hypoglossal nerve.
Almost. What's the exception?
The palatoglossus muscle. That one gets its supply from the pharyngeal plexus. A classic exam question.
Definitely a nugget to remember. Okay, let's shift to the teeth. The grinders.
We get 2 sets, 20 deciduous or baby teeth, and 32 permanent teeth. And knowing their basic shape is key. Maxillary incisors are bigger than mandibular ones. Canines have the longest roots.
And let's break down what they're made of, the microanatomy.
So the outer crown is covered in enamel. It's the hardest substance in the body, about 96% mineral.
And it doesn't grow back.
It can't. It's non-living. Once it's gone, it's gone.
And maybe that.
Is the dentine. It's yellowish, forms the bulk of the tooth, and it's laid down slowly throughout your life. It's filled with these tiny tubules.
And in the very center
is the pulp. That's the living part, connective tissue, blood vessels, and nerves. And those nerves only register one thing.
Pain.
Just pain. Hot, cold, pressure, it all just registers as pain.
What about the root?
The root is covered in cementum, a bone-like tissue. Its job is to anchor the tooth into the socket via something called the periodontal ligament, the PDL.
And that PDL is more than just a tether, isn't it?
Much more. It's only about 0.2 millimeters wide, but it's packed with sensors that tell your jaw muscles exactly how hard you're biting. It's a shock absorber and a sensory organ.
And this brings us to a major surgical risk, the wisdom tooth and the lingual nerve.
Yes, a huge vulnerability. The lingual nerve runs incredibly close to the mandibular third molars. Sometimes the bone between them is paper thin.
So an extraction can easily damage it.
It can. And that can cause paresthesia, altered sensation in the tongue. It's why tools like CBCT scans are so important now to map out exactly where that nerve is before surgery.
Right. Okay, let's move on to the secretors, the major salivary glands.
The parotid, submandibular, and sublingual. They make saliva for lubrication, digestion, defense.
And the output changes, right?
Dramatically. At rest, the submandibular gland is the workhorse. It makes about 65% of your saliva.
But when you eat?
The parotid gland kicks into high gear. Its contribution jumps to about 50%, producing this rush of watery, serous saliva to help with digestion.
And anatomically, the parotid is the biggest, mostly serous. The sublingual is the smallest, mostly mucus. And the submandibular is a mix.
And its duct has that famous relationship where it crosses over to the lingual nerve on its way to the floor of the mouth.
And how is all this controlled?
The main drive is parasympathetic, But there are also these fascinating contractile cells, myoepithelial cells, wrapped around the secretory units.
So they squeeze.
They literally squeeze the glands to help expel the saliva more quickly. It's a mechanical boost to the chemical signal.
A biological squeeze bottle. I like that.
Mhm.
Finally, let's tie this all together with the clinical idea of potential tissue spaces.
Right. These aren't empty spaces. They're just areas of loose connective tissue. They only become a space when an infection, like a dental abscess, tracks into them and fills them with pus.
And the path that pus takes depends on that muscular floor we talked about.
Exactly. The mylohyoid muscle is a watershed. If an abscess from a lower tooth breaks out above the muscle's attachment,
It goes into the sublingual space, swelling in the mouth.
correct. If it breaks out below the muscle attachment,
It goes into the submandibular space, and you see the swelling in the neck.
it's pure mechanical anatomy.
And there's one last, really terrifying pathway from the upper jaw.
The danger triangle of the face. An abscess from an upper canine tooth can track up towards the orbit, and the veins in that area, the facial veins, don't have valves.
So the infection can travel backward?
It can travel straight back through the ophthalmic veins right into the cavernous sinus inside your skull.
Causing cavernous sinus thrombosis.
A life-threatening emergency. It's a direct, dangerous anatomical highway.
So we've mapped this whole region, from the roof down to that fragile bone over the lingual nerve. It's just a marvel of functional complexity.
It really is. And here's a final thought to leave you with. Remember the enamel and the dentine? They lay down incremental growth lines like tree rings.
Right, the striae rettius in enamel.
Yes. And these lines, especially the very distinct neonatal line that forms at birth, permanently record any major physiological stress.
What do you mean?
A major childhood illness, a period of malnutrition. It disrupts the mineralization process and leaves a permanent mark, a distinct line in the tooth structure. It writes a biological record.
So when you look at a cross-section of a tooth, you're not just seeing anatomy, you're seeing a life history written down day by day.
A biography in enamel and dentine.
That is a breathtaking idea.
Yeah.
Go forth and observe. Thank you for joining us on this deep dive.